Hi, good morning everybody. The next training we're going to be doing is on cultural competency. This kind of training's been around for quite a number of years. Has anybody gone to a cultural cultural competency training? Yes? And we have a course on it. Okay, we have a whole course in our ACT program. Do a little plug on it. So this training, like I said, is usually much longer, so I'm just going to, shrink it in. I got a half an hour. And cultural competency is basically indicating that we have to treat each individual we interact with differently based on who they are. Now we just went around and everybody sort of said, their professional background, their maybe educational background, but also there are other components, other situations that make up who we are today, correct? And there also are situations that make up who a client is today, okay? So like I said, if there's conflict between staff, sometimes it's a cultural piece. People will say, well, oh my gosh, I would never say that, or I would never dress that way. But maybe that is part of the culture, where someone comes from. What would be some other things that make a client who they are today, besides their education or vocational background? What do you think? Their religious beliefs? How about anybody else? We're sharing our wealth with people.
That they grew up in?
Their environment.
Gender and sexuality.
Gender, sexuality. Anything that makes up who they are. One of the things I want to mention is, do you ever meet somebody, because we have they say within 45 seconds, you sort of will have a first impression of somebody. Anybody ever do this? And then you get to know them completely different, right? That is what we're talking about. And what cultural competency is inquiring to the person how this may or may not have affected them. And it depends where we are in the client's growth process. Now, if someone's working in detox and you've got 5 days with the client, you're not going to get into depth with a lot of their background. If someone's working with a client for 3, 6, 9 months, obviously you're going to get into a little more depth of who they are, because we want to service them where they are, not where we are. Okay? Everything we do is regards to culture. We have our own cultural filters based on our background, okay? And what we have to be careful of is those cultural filters don't impact our interactions with clients. And the term there on the bottom bullet around stereotyping or bias, a lot of people say, I don't have bias. I don't stereotype clients. I treat everybody the same, okay? And that may be the case. But we have to normalize, really, that there is bias. We all have bias based on our cultural filter and our life experience. And the importance is to realize that if it's impacting our interaction with clients, we need to get supervision. So people will say, well, what does that mean? There's formal supervision where a manager, director sits down with someone, required one-on-one or in a group setting. So, the frequency depends on the contract. But in between, there's a lot of things that happen to us that we may not know how to handle. Or staff may feel uncomfortable interacting with certain clients. Maybe they remind them of someone that they didn't have a really good interaction with. Okay? Maybe there's some other kind of bias that appears that we have to work through. We recently did an all-day training on cultural competency for the state, and we had about 60 in attendance, and one of the things we did, and as a trainer, it's like a dream to have an all-day training, is we asked the participants just to go in the back of the room, and on a scale of 1 to 10, having a little bit, actually 0, having no bias, up to 10, having more bias, most bias, to stand where they think they'd be on that spectrum. And it was interesting because some would start here and they'd go, oh no, I remember that situation, or, oh, do you see what I'm saying? And move. Because if we don't normalize that we're having some bias it becomes more influential. Right? So finding out how you get in touch with your supervisor in between those formal supervisions is important. Right? And what's important with that is the awareness that none of us have all the answers. Right? And to be able to find out, do we text? Do we email? Is there some kind of indicating this is an emergency? Or can I speak to you next week? Or can I have a telephone, consult or whatever? Same thing, I have to do with my boss. We were smaller. When I started here, we had 3 programs and 175 employees. And right now, like I said, we have 36. And we have 1,700 employees. So people say, Ann, I never get to see them. I said, no. When you work in second shift or third shift, you have to get creative. And I usually indicate to people to try to do something that you can see that's documented. Because you may have, and we have a great management group, about 80 members of the management group, but wherever you go, because maybe your supervisor will change, you get this, say, okay, why don't we handle it this way, and then the next month someone will say, well, why did you handle it that way? Okay? So we have to be very careful around the bias and their interactions, which will tie into the next training on ethics and boundaries. Okay? All the things that make up who an individual is. And what cultural competency is not assuming. It's inquiring. Because other than that, then we may be experiencing, I should say some staff, not we, should be experience that stereotyping or a form of discrimination. Okay. And to focus on one's strength. Here's some other cultural considerations. Okay. So you have a situation where the basic premise with this type of training, when it was mandated, was to talk about linguistics or language, okay? Was that we have to offer documentation and the ability for clients who do not have, whose primary language is not English, to be able to engage in treatment, right? And so we have to offer those types of intake packets in other languages. We have to get in touch with the state if we need interpreters. We track employees who are bi or trilingual, and that may be a requirement of their position. And that includes ASL. I've worked with hearing impaired clients in that residential program. It was very interesting to have varied languages and culture in that program. So it's providing those things that the client needs. Now, perhaps the client is fairly fluent in English, but may not be as proficient in writing or reading in English. And I'm sure some of you, and I know I've had to help clients with assignments because there may be some shame that they can't read or write. And unless we ask, can I help you with this? Or I'm noticing that, because there is shame, or that maybe they're illiterate. Maybe they've never learned to read and write, regardless of their language. But if we don't inquire, we don't know. How many people have had to do that for clients? Help them out, right? They may be very direct. I have clients who just say, right, I need help, or maybe a peer, and others who you see some reluctance or what have you. That's cultural competency. That's not, we don't want to impact the shame and guilt of clients coming into treatment, right? Which they already have. Race, okay? Culture, their ethnicity, okay? Their background. How has it impacted them? Could be positive, could be negative, right? Has there been social trauma in their country of origin? Did they bring that with them? Gender. People work with varied genders. okay? Do you think, and again, in general, they respond differently to engagement or medication or anything else? I'm just talking about things that come up with trainees on Mondays and Tuesdays, right? Things like that that can occur. And you find that you may, over time, realize the kind of client population you enjoy working with. And don't discount that. And sometimes staff may find out there's certain populations they don't really enjoy working with as much. And that's why it's important to find out what works and doesn't work. And that's one of the reasons we do a lot of job matching in HR. You know, we usually have about 150 positions open at any one point in time. And those are sent out every week with all of our trainings from the HR department. Because after the 6 months or so, out of respect for the hiring supervisor, sometimes working with employees, that they just may be needing a change. So we allow that internal postings before we hit the Indeed or any of the other internet options. Socioeconomic status, okay? Very different for each person. A lot of people say, well, they're coming in, they've lost everything, they've lost their family, their house, they're this, they're that, they're in crisis, and that is usually the case, but not all the time. When I work with employee assistance programs, a lot of times we would be referring employees into programs where they still are holding on to their job, the last frontier. They may be very economically stable, but not necessarily emotionally or spiritually, okay? I skipped age. The average age of the clients that we're working with now is 25. That's across the state. Much younger population because of the opiate epidemic. And so we're not only dealing with the high rates of relapse and overdoses, which a lot of agencies have experienced, including High Point. We're dealing with impulse control piece. You know, the frontal lobe of the brain is not usually developed till age 25 either. Okay, so if we're dealing with populations we're dealing with impulse control, you know, anywhere from 18 to 25. Very demanding on staff. Very demanding. So, I see a lot of head shaking, but I can't ask questions. We talked about primary language, English proficiency. We've got to accommodate for varied body sizes. For it, you know, usually all our beds are longer length, all right? But someone may need larger chairs or different size wheelchairs. We have to accommodate for those kinds of things environmentally. Spirituality and religion. Now, this may not be significant at all to some clients, but it is to others. And spirituality can be very different than religion. And to sort of separate those a bit, because many of the recovery processes are very spiritually based. And that is a growth process for many clients, okay? But we also have to be aware of that their rituals or religious practices or beliefs have to be respected while they're in treatment. So if we have the ability in some of our settings, especially our residential settings where there may be transportation restrictions, to bring clients out to certain services, we have to be open to bring them to a few, like we would do. Okay, and it may not be all on Sunday mornings. Or we may allow clergy or spiritual consultants or whomever to come in for visitation. Right? We know there's dietary restrictions based on certain religious practices. We have to allow fasting. We have, you know, all of those things. Okay. I'll talk about sexual orientation in a minute. Physical limitations, medical situations. What are clients coming in with? You know, they're coming in with Hepatitis C, 70 to 80%. Some know about it, some do not. They're coming in with mobility impairment. They have neuropathy, right? They're coming in with cancers. Any of you nurses can, and we see it. Some of the other things you see. Anything else you've seen with clients coming in? Medical issues. Diabetes. Okay? I'm just thinking of what people say. All of these kinds of things clients come in with. It's very hard. Where do you start? You start with where the largest need is for medical or psychiatric stabilization. Right? That is what's most important. And I'm sure they're coming in with other things, but I can't think right now. But I'm sure you can. Okay? Makes it very demanding. Many have criminal justice involvement, right? They've had arrests, they're referred in from parole, the DA office, probation. So you have a lot of those other concerns around what they're able to do and not do, what they have to do. Okay. I know I also do psycho-ed groups for first offenders groups. I've been doing about 7 years for driving under. And so there is a lot more consequence for that client population or for our mandated clients coming into treatment. Now here we have our hospital's been here probably 2.5 years. I think it's a 70-bed hospital, right? Primary diagnosis, psychiatric. Secondary diagnosis, addiction. Our addiction programs, criteria, right, is usually you see addiction first and the mental health diagnosis. Here, the psychiatric diagnosis may be a little more severe. And what happens is clients are sectioned into treatment under what's called a Section 12 because they're at risk of hurting themselves or others due to their psychiatric diagnosis. Now, about 10 years ago, the state came up with new contracts called Section 35 programs, where clients are mandated into treatment through the courts because they're at risk of hurting themselves or others due to their addiction. Now, the clients who are mandated into treatment, very different population to deal with. Okay? The first contract we had was the Women's Addiction Treatment Center in New Bedford, which is right now expanding over 100 beds. Always full. The second program we got the contract for was the Men's Addiction Treatment Center up on our Brockton campus, about 100 beds. Right? And the third program we have is High Point at Jamaica Plain, which is a women's facility for Section 35. So you see the variance of the voluntary versus involuntary population, much more demanding on staff, but staff at times feel they have a little more leverage with the clients. Okay? All right, I'm going to go out of the area, visual area, and I'm going up to show you one other slide. Now this one is hard to see. But I'll go up there and read it a bit. We also have to be aware that clients presenting in treatment are much more fluid around who they are, not just with their sexual orientation, but how they identify. And we have to accommodate individuals. And we have plenty of policies on it. All right, so I'm going to go up. I hate going up here, but I'm going up. Workers' comp. So this is called the gender person. Not that you would ask this of clients, but some clients, depending on where they are in treatment, this is important to them. Okay? And nowadays it's not just indicating are you homosexual or are you a gay female or are you a gay male? Nowadays, it's very different. We just had a great 3-hour training by Praxis. If you ever see any of the trainings on the document we send out called the HR link, what I just mentioned, try to attend. They're unbelievably It's proficient. They're very proficient, and it has all continuing education for all licensing boards. So now the question is, how do you identify? Some people may identify as a male or a female, biologically. They may be in transition physically because they're transgendered. They can be transgendered without going through any physical transition, more of a social transition. We need to know about these populations because it's very high risk for trauma, and they've experienced a lot of that and within their community, and high rate of suicide. Okay? So I'm just going to mention a few of these. Not that you would say it specifically for these clients, but the questions: how does a client in their head define gender based on how much they align or don't align with what the options may be? Do they identify, like I said, gender identity, more as a woman or a man or both, someone in the spectrum? Gender expression, the ways a client present their gender through actions, dress, and demeanor, and how the presentations can be interpreted. Biological sex, the physical sex characteristics a client is born with and develop, including genitalia, body shape, voice pitch, body hair, hormones, chromosomes, estrogen, what have you. Again, on a spectrum. And then who are you sexually attracted to? Nobody. And that can include heterosexuals, women, men, both. Romantically attracted to? Nobody, women, men, both. Is this a little more information than we've ever needed to ask before? How about sexual arena, when we're talking about harm reduction? And that should be something explored with heterosexuals, especially with, their trauma history and sexual compulsion. All right? So what do you think about the gender bread? Make sense? Okay? More on that. Now, clients are coming in, and we have to make a special accommodation depending on how they identify biologically. And we have a policy on that. It's in my other thing, on dealing with varied genders and transgendered client population. Technically, they're to be placed, and this is under the Department of Public Health Bureau of Substance Abuse Service recommendations, in a facility that they biologically identify as. Now, this is very new for other clients and very new for staff. Okay? And how many people here have worked with different identified populations? Okay? We have to be, and if we're not aware of interacting with them, we need to get a consult or educate ourselves. Right? So that's what we're talking about with cultural competency. And we have to be aware that if that bias is there, if there's certain populations that a staff member may not feel comfortable interacting with, we have to voice that and see if we can accommodate. But maybe if that's part of their job description, they're really going to need consultation. Maybe it's a client that really is impacting or causing some confusion for an employee because of their value system. Right? The staff, I don't want to work with sexual offenders. Yet we have staff at facilities, that's their expertise. We have staff at facilities, expertise with transgender population.